Hello everyone, welcome to the fifth video lecture for our Sociology of Health and Well-Being class. And for this session, we'll talk about the Sociology of Health Behavior. So these are what we're going to be covering for this particular session. We will be trying to understand what healthy lifestyle means. So you might have heard about that, or that phrase might have been used by you or the people around you, and there seems to be a common understanding of what it means or what it entails. But let's just look at it on how it's understood, at least based on what the different health institutions or agencies sort of think about it. And then we'll talk about the different theories of health behavior and health promotion. So this is not just very much anchored simply on sociology. These are transdisciplinary theories, but of course we're going to be also looking at them from a sociological perspective. And then we'll talk about the micro and the macro social factors of health behaviors, distal and proximal social determinants of being able to do health behaviors or having positive health attitudes, and also interrogating how can we make use of social sciences and sociological thinking to be able to change health behaviors. Of course, what we want to have is we want them to have healthier behaviors, but at the same time being able to diagnose why people change their behaviors for the worse, so that we can further understand how to make health behaviors better from a sociological standpoint. And so we also have to look at why it's important for us to talk about lifestyles, right? The choices that we make every day, the things that we do with our bodies, to our bodies, through our bodies, and how our seemingly day-to-day choices influences our health, either acutely, like for example, if you are a person who likes to take risks, does a lot of extreme sports, then that puts you at a greater risk for injury. But also chronic, cumulative risks, like for example, if you're eating a lot of meals that are processed, high in saturated fats or high in sodium, that increases your risk for cardiovascular disorders over time. And so what are the big five of lifestyle choices that are considered as dangerous for your health? So syempre unang-una dyan ang smoking. So I will not be getting into the nitty-gritty of like the biochemical changes that happens because of smoking. But yes, smoking increases a lot of diseases, increases the risk for a lot of diseases, including cancer, including cardiovascular diseases, cerebrovascular diseases. It also has an effect on your skin, on your lungs, of course, your liver, etc. Poor nutrition, and this is, overnutrition or undernutrition. So when we say overnutrition, eating too much with saturated fats, trans fats, low fiber, high in sodium, high in sugars, high in preservatives. Although, of course, preservatives is a term we use a lot. But yeah, and of course, not eating enough, micronutrients from natural sources like vegetables and fruits, etc., etc. Physical inactivity or sedentary lifestyle, right? Not burning enough, not doing a lot of cardiovascular exercises, diba? Ang requirement kasi is that you should have 20 minutes of increased heart rate for 3 times a week. Yan yung pinaka minimum for us to be able to say that we are not doing like a fully sedentary lifestyle. So, and then excessive alcohol use. Although there's already like Kasi for example, no, when we talk about smoking, there's no like moderate smoking. Like all forms of smoking, kahit isang half lang yan or isang stick lang yan, already has damage done to you. So there, you cannot say smoke responsibly. No, you say immediately that smoking is bad for you, and this is not the same with alcohol use. At least in general consensus, no, parang there is a safe threshold for you to to say that yeah, the amount of alcohol that I'm drinking is still okay, although there are already arguments that sort of say that no, all forms of alcohol is not safe. So again, there is a moving science in relation to this. Yeah. And of course, not necessarily a lifestyle choice, but an effect of some lifestyle choice. Of course, this is not just lifestyle. Of course, obesity can, can mean that you have genetic issues, biological, biochemical issues, but obesity can also be a result of poor lifestyle choices or poor lifestyle performance. No, not really choices. We'll talk about choices and being able to actually perform them later sociologically. But yeah, obesity increases a lot of issues. It increases risk for many diseases. Now, these are some examples of DOH campaigns for healthy living. And these are very important because when you go from one country to the next, the way they would define healthy lifestyle would be different. It would be contextualized based on, of course, the language of who we're communicating with, the contexts of what how they can engage with. Like for example, in Australia, a part of their healthy lifestyle would be to always wear sunscreen, particularly many decades ago, wherein they're directly affected by the ozone layer thinning. So they are at higher risk for skin cancer. So it's like a daily thing that they have to talk about. Like you always have to wear sunscreen. In the Philippines, while of course we want everyone wearing sunscreen as well, but that's not something that we promote as vigorously as what they do in Australia or in there, because they're so much at risk for skin cancers. So again, healthy lifestyle would be different, across context. So we'll just zoom in about what DOH thinks is a healthy lifestyle. And also, I don't know how often you look at their specific websites or their promotional materials, but you would also notice that across decades or across whoever is the sitting secretary, the way they would communicate it would be different. Their priorities for what healthy lifestyle mean would also be different. So one sociological thought of that is, again, parang healthy lifestyle, the way, there are activities that brings us to, protect us from illness, brings us to a better point of wellness, but the way it's prioritized and communicated to us differs based on social reality. So in the Philippines, we have 7. So according to Move More, Eat Right. Dati magkahiwalay yan eh. Magkahiwalay yung exercise at saka nutrition. So in this case, they're put together. So very metabolic ng atake. Next, we have Be Clean and Live Sustainably. So environmental health is something that again, DOH seems to prioritize. Next is get vaccinated. Yan. This is an example of a targeted primary prevention. Diba? And then don't smoke and vape. So again, there are now increasing studies about vaping being also problematic in terms of health. Maybe not as exaggerated in terms of the amount of information that we have for smoking, but vape is already sort of kind of noted as a problemac health behavior or behavior activity. So avoid alcohol and say no to drugs. Again, drugs is also noted as an important lifestyle issue, particularly in the Philippines, where we know this is a widespread issue, right? And then care for yourself and care for others are very externalized, no, ang lifestyle. So this is again, no, with the um, increasing concerns about mental health. So may ganito na rin. Practice safe sex. So for them to have a separate, notation on practice safe sex, I think this is something that's different from way before when we were being taught about healthy lifestyle. And then do no harm, safety first. So again, talking about, seat belts, and other forms that will of preventing accidents. So this is an example of, national health guidelines by the DOH. It might change based on who's sitting as the secretary, based on priorities yan. Ito naman, they're showing us mental health checklist. So makipag-usap sa pamilya at kaibigan, very Filipino, magpahinga ng sapat, mag-ehersisyo, kumain ng masustansyang pagkain. So these are very behavioral-oriented mental health self-care. Uminom ng tubig, makipag-usap sa mental health professional kung kinakailangan at magbasa ng libro. These are, again, self-care tips. And, let me just put it out there to problematize self-care, because one issue that I have with self-care is that it puts the responsibility of health dominantly on the individual. Well, in fact, not all individuals have the means to be able to choose or to be able to enact these things. Like, for example, being able to talk to a mental health professional is sometimes a privilege for people. Now, you would argue, meron naman pong libreng mga mental health practitioners that can be accessed using NCMH. That is true, but these lines, for you to be able to get through, this queue, for you to be able to actually talk to a professional who on the other end of the line is already very much exhausted with a lot of calls that they receive, is already something that people of privilege who can, talk to a therapist even for minor psychiatric issues, not really psychiatric emergencies, have the money for them to, actually pay a psychiatrist or psychologist to talk to them, to have a what do you call this, a schedule with them, even, preemptively, is already a gift, or be in a school wherein the guidance counseling system is not as saturated, Maswerte tayo, for example, in De La Salle, we have a really well-staffed, counseling psychological services, with, there is a staff that is available at a certain given time at a certain, for a certain sector of the population. Even graduate students have, their own CPS providers. And again, it comes with privilege, and you can just imagine, like, there's only one guidance counselor for, let's say, one, public elementary school with thousands of students. So how can you expect that, single guidance counselor to take care of the mental health needs of all these people, in the school? So, and how can you expect these children to, meron namang guidance counselor, but hindi ka pumunta doon? So again, the issue of putting articulating self-care, is problematic to me, because again, it puts the responsibility to be well on the individual, when we know that being well is not just a function of an individual doing, but also the structures and the context that they are situated in. This one is very interesting. We have Pinggang Pinoy, and this is a very good visualization of how we should portion our meals based on the type of food. So that we have the go, grow, glow. The go for carbs and starches. You have grow for proteins, and glow for your micronutrients, vitamins, and minerals. And basically what it does, it visualizes what a plate should be in terms of portions, So, ayan. And then meron na tayong per developmental stage. So, Yeah, this is actually copied from Healthy Plate or taken or ano ba, adapted from the United States Healthy Plate at ito naman ay tinawag na Pinggang Pinoy. So this is naman for nutritional behaviors. Yeah, and then we'll talk about, are you really able to follow this? Like if you are an individual who does not have much luxury to buy a lot of protein-rich meals, then maybe you need to increase your go foods, your calorie-dense foods, carbohydrate-dense foods, which, of course, can lead to more glucose build-up and storage in the body, causing, increasing fat deposits, etc. So, again, we'll talk about those, ability for you to actually adhere to this Pinggang Pinoy or healthy plate. And then, of course, these are the other health behaviors that we expect, certain people to have. Like, for example, family planning is, again, considered a health behavior. It has its own science. It has its own subject in the public health domain. Why? Because we do know, no, and you don't have to be a sociologist to know that, family planning behaviors, contraceptives, reproductive health is not really just an individual, thing. It's not just your motivation, your attitudes towards it. It's a lot of society creeps into the choices that you make, for family planning, etc. No, so again, this is one of the health behaviors that sociology needs, or social sciences needs to be more present in, because we do understand that sexual act behaviors, even within and outside marital relationships, are heavily sanctioned, by the state and also by religion. And so these are the things that we have to sort of look into. At the same time, the choices that they have for the family planning options, like, will they have access to contraceptives? And what type of contraceptives are they? And this is not just talking about, yeah, sure, the responsible parenthood plan allows you or mandates that you have to have all of the options available, including both natural and artificial family planning. But is it available? Or do you live in a community where that's shunned upon? And I have been. I have worked in a community health setting wherein there's this particular resettlement area that is managed by the nearby parish, that even during the time of responsible parenthood enactment, they really do not allow the midwives to come into the to the homes for them to teach about family planning, because they don't want them to use pills or things like that. So again, sexual health or sexual behaviors, even if it's most private moments in enclosed spaces, po nakakapasok ang estado, nakakapasok ang relihiyon. And so, sociological theory, sociological perspective is very important. And of course, HIV, let me just, of course, take this time to also educate you a little bit about HIV. So, it's a sexual and a blood-borne disease. Some myths to dispel. You don't get it through saliva. You don't get it through mosquito bites. You don't get it from sharing toilets with a person who is infected, right? Ayan. So, and it takes, viral sufficiency and actual exit of the causative agent and, a portal of entry for you to actually have HIV. Right? It also be blood-borne, meaning you can get it from the usual is sharing needles or during drug use. Another would be you get it through blood transfusion, but that is almost impossible nowadays with the amount of work that we do to check blood bags before we transfuse them on people. The whole HIV can be talked about in a full 3 unit course, because this is, again, this is a transdisciplinary thing. It's not really just talking about the biology, the virology of these things, but also we have to talk about behaviors. We talk about gender as well, of course. We talk about structural issues, societal issues, stigma. When we talk about HIV and AIDS, but usually a common way for us to sort of talk about HIV prevention is the ABCDE approach. So you abstinence, But this is nice because abstain from unsafe sex. So it is, so meron ng mga frames about desire-centered sexual health. So ibig sabihin, you're not being stopped from having sex. You're just being asked to abstain from unsafe sex. Be mutually faithful. I think the mutually part is important because you can be faithful, but if your partner isn't faithful, there's still a chance of you getting it. Correct and consistent use of condoms. Don't share needles and avoid drugs and alcohol, and educate yourself about HIV and how to prevent it. And of course, consistent use of pre-exposure prophylaxis or PrEP. So again, that's a whole story, and we'll not get into that. But yeah, so just sharing this with you. And if you have questions about this more, we can talk about it in class. And then, of course, other disease-specific health behaviors. Of course, your social distancing, So, and we know that in the context, of COVID-19, during the time that we were saying, you have to stay at home, you have to wear masks, you have to wash your hands all the time, you have to use alcohol all the time. We do know that these are things that are true and are right, but we do know that not everyone is following. And I think that is a wake-up call for everyone na parang, you just don't teach people to do what they need to do to protect themselves from health problems, but there are many layers to it, like kung wala naman talaga silang mapagkakitaan, and the only way for them to have money and survive is to really go out of their house and work, even in a very dangerous position, So we've seen that, and then of course itong 4S in fighting dengue. So this will of course require collective behavior, kasi parang kahit ikaw lang ang mag 4S parang hindi siya magiging effective. Kasi for example, if not everyone is doing search and destroy, edi mag-search and destroy ka sa bahay mo, pero kung yung kapitbahay mo hindi nag-search and destroy at doon namuo yung mga Aedes aegypti na mosquito, then you might still have dengue. Seek early consultation, secure self-protection measures like wearing long sleeves or putting lotion on yourself, and then support fogging or spraying in hot spot areas, But of course, ayaw din naman nila ng indeterminate like fogging, So you really have to talk to the municipal public health office, to coordinate these things. So again, all of this are all health behaviors, different contexts, different disease orientations, But again, I haven't really talked about the sociology of everything yet, but you can already imagine, hopefully in your minds, where society comes into the picture, even in these individual decisions of, using condom, individual decisions of using oral contraceptives, individual decisions of getting masks, individual decisions of, being able to follow a healthy plate, individual decisions of, accessing mental health care, preventive and also curative mental health care. There are already a lot of social gradients to it. And so that is where sociology comes into the picture. We always, and of course, something that we have to think about when we probably had an interaction with a medical physician or a health professional, and sort of, I don't know now, but I think the dominant way still, that many of our health professionals sort of treat people for like getting obesity or getting cardiovascular illnesses or any form of or diabetes or cumulative health diseases is really, blame the patient for for what has happened, for making those choices. But tayo, as social scientists, we know that choices aren't as strong as life chances. And Weber, has taught us this, that there are two distinct influences on lifestyle, which is, of course, the our the way we conduct our lives through personal self-regulation, and life chances, the options that we have, or structural probability for us to actually do the activity. So for example, very simple example, you wanna be more active, run, wala ka namang matakbuhan kasi walang runnable space. You have to go to BGC to run, and that will be cumbersome for you. It takes a lot of time, and that time that is lost can cause economic decline for you. So hindi ka privileged or incentivized to run. And so ito na yung agency at saka structure na pinag-uusapan natin. Agency, your ability to actually do the things based on your personal volitions, and structure, the extent to which the structure constrains you, social reality constrains you, whether that is, those are the chances that you have, opportunities that you have, and that is also very dependent on your social position. So let's talk about the different health promotion and education models. The first one that is used across disciplines is the health belief model. This is coined by Rosenstock, in the 1950s. And basically, these are the different factors that influences a person to take action. So what increases a person to take a health action? One, if high ang kanyang perceived susceptibility. If the person believes that they are susceptible to the disease, they're more likely to take action. If they don't feel like they're susceptible to the disease, they're less likely to take action. So for example, I'm not very old. I am also not very young. So I don't think that I am susceptible for COVID. So I will not get vaccinated, or I will not mask myself up. Or bata pa naman kasi ako, I'm still young, so I can still expose myself to some puffs of cigarette smoke or to eat trans fats kasi bata pa naman ako. I don't think that stroke will be a reality for me, this is going to happen to me only after 40 years old. So for me to cut down on the fats that I eat is not something that I would do. So, perceived susceptibility. The lesser you perceive yourself to be susceptible to the disease you're trying to prevent, then the lesser you are in terms of action. Perceived severity. Gaano ba kalala ang tingin mo doon sa mangyayari if you did the action or did not do the action? So the more severe you think the consequences of that action or non-action is, the more you will do the action. So for example, you think, I don't want to take a mask. Yeah, siguro I would get COVID. I don't think naman that COVID will kill me, right? I don't think it will be severe on my end because I am not that very old, or I am not that very young. So, it's easy. It's okay for me to not use, masks. Yeah. So, again, perceived severity. Or, maybe, naman kung ako ay magkaroon ng flu for today. It's just flu. Nobody died from flu, or nobody died from a few sniffles. So, I'd risk it. Those kinds of the beliefs, And then perceived benefits. If they feel like doing it has more benefits for them, then that increases the action. So for them, if if I if I do diet, if I exercise, I have a sexier, thinner, leaner body. It will make me more attractive. So I'm more likely to do it because I see benefits of that. And then also perceived barriers decreases. So for example, hirap mag-exercise kasi malayo yung pagtatakbuhan. Wala akong oras for that. So I don't have time for it. I don't have the space for it. I don't have anyone to be with me. So that's a perceived barrier. The more perceived barriers decreases the action. And of course, generally, your motivation, internal, intrinsic motivation, and external motivation. And of course, these things are influenced by, many factors like your class, your gender, your current age. Syempre, when you're older, your perceived susceptibility is higher, perceived severity is higher, etc. And of course, this has something to do also with psychological characteristics like your personality, if you're looking from a psychological parlance, no? But also, many of these are also sociologically, external motivation, peers, etc. And so those are important. So, like for example, this is used, if you by some people to communicate or promote behavior. Like for example, we want people to exercise more. Then we tell them that, you know what, you're not too young to get stroke. And stroke is so bad, we've seen 20 plus people already have stroke as early as 20s. So you can't be susceptible. So you have to do, if you can, engage in exercise, you have to engage in proper nutrition. And then, or you amplify the benefit so that they perceive a better benefit. No? Again, the usual sexy body, you look better in your clothes, etc. And then you decrease the perceived barriers. Hindi ko alam, wala akong oras. Okay, let's see. Let's structure your time so that the perceived barriers would be lesser. And that's exactly the importance of cues to action. So, meaning, they have to know that the action exists or it's an option for them. Right? Because maybe we talk about why people exercising or doing this particular meditation or mindfulness exercise. If they don't know what mindfulness exercise is? So cues to action is very important for them to actually know that the action is an option or it actually exists. They know how to do that particular action. So vaccination, for example, like getting vaccinated, blah blah blah. What's the cue to action? Do you get an information that the vaccines are already available in your unit, etc.? Yon. And then this one naman is the theory of planned behavior, no? And the theory of reasoned behavior. So yung blue is the theory of reasoned behavior. The green, together with the blue, is the theory of planned behavior. So ang argument dito is that all behaviors that are planned or intended increases the actual engagement of the behavior. So, syempre, if you intend to do the behavior, you're more likely to do the behavior. So, ang question is, what now will increase your intention to do the behavior? So, there are now 3 general factors. The first one is your attitude towards the behavior. No? Do you have positive attitudes towards the behavior, negative attitudes towards the behavior? So, if you have positive attitudes towards the behavior, you're more likely to intend to do it and ergo do it. Subjective norm is the behavior you're thinking of something that's socially acceptable? Do you expect your immediate and distal social groups to see you supporting doing that behavior? No, so if social cues and social norms have a positive bearing on the behavior, then you're more likely to intend to behave in such a way. And then perceived behavioral control. Can you really actually do it, use it? How confident are you to actually do the activity? No, that's the other thing. No. So, and then of course, under this, you have behavioral beliefs, behavioral outcomes, normative beliefs, motivation to comply, control beliefs, and perceived power. But usually, this is the box of the theory of planned behavior by Asgen. And then when you think about it, so this again, no, it sounds very psychological, but at the end of it all, like for example, your attitudes towards behavior is influenced by social realities and chances. Subjective norms is very much influenced by social reality. What your parents think of you, your family would think of you in relation to that behavior, etc. Is there a stigma around that behavior, etc. So yun siya. So now let's talk about life chances, right? So we talked about, the extent to which a person has enough chance or structural incentives to actually do the behavior, fundamental causes, etc. So we do know that those coming from low socioeconomic status, lower classes, lower education, lower income, occupations that are really time-consuming are less likely to engage in healthier behaviors. And we've seen in the books, some examples of how this plays out in real life. So for example, those who have higher income are more likely to be able to buy the tools for health, like access to nutritious food, safe neighborhoods. They have an occupation when they have annual physical exams, so that just in case they have, heart issues, they could be screened immediately before it becomes bad symptoms. Again, remember, the issue for prognosis is that prognosis is better when diseases are identified before the symptoms come out or before, the symptoms worsen. And then at the same time, education teaches agency. Like for example, maybe, for example, disaster resilience, no, or nutrition, for example. You have nutrition month every year. When you were in elementary, naglalakad pa kayo at kayo ay nakasuot ng mga para kayo, iba-iba kayo mga gulay, iba-iba kayo mga prutas. And that kind of increases, your information about, gulay at prutas ay important, for health, But if you weren't exposed to education, you wouldn't know those, You might not be able to know those things, etc. And also, there are mandated laws where in workplaces and educational institutions are supposed to take care of you, like the mental health law. Workplaces and educations must have programs to take care of the mental health of the people under their care. So again, if you are an out of school youth, or you're out of school, or you're unemployed, then you might not have those benefits that the state mandates workplaces and educational institutions to have, right? So, and we see here now in American numbers, those who have high school degrees were more likely to cease smoking after a heart attack than college graduates, because again, they have more life chances, more choices, for them to be actually there. So again, class is very important. Like for example, you talk about access to exercise. Saan ka naman mag-exercise if you live in a slum, or in an area wherein, like for example, dun sa area na pinupuntahan ko sa community, like you have very, very narrow roads. And then dami nakapark na mga kotse. Saan ka magtatakbo? Diba? And then, marami kang exposure sa pollution. So wala kang choice. You wanna meditate, you wanna do mindfulness activities. If you're rich and you have a large house, that's easy. Pero when you live in an area, in a crowded neighborhood, naririnig mo yung chismisa ng mga ate sa baba, naririnig mo yung inumin ng mga kuya sa baba, how can you do mindfulness exercises if you actually have information about mindful exercises at all? So again, that's the danger of self-care. It assumes that everyone has, enough materials, cognitive agency for them to be able to do things. They have the cognitive tools to do things, the material resources to do things. But, we know as sociologists that based on our class positions, we don't have that. that's an uneven thing, no, in our reality. Again, no, we also talk about, different other, socioeconomic gradients and also demographic gradients. Like, for example, females are more likely to seek preventive care than men because, again, masculinity is very much coded to macho, being macho. Ay, kapag may sakit, kaya ko to, lalaki ako. No? I'm a man. I can brave through, I can soldier through all of these symptoms. While women are more likely to seek more care because they're socialized, no, to become because they're carers, no, so they're also socialized to seek preventive care. They're more likely to wear seatbelts and wash their hands, 88% versus, but they exercise less than men because, again, exercise, being sweaty and all is a very masculine coded, like mannerism, aesthetic, etc. And so, yeah. For race and ethnicity, minorities generally face higher risk due to, again, lower socioeconomic stress. And we've talked about social stress before. This is the same with indigenous peoples in the Philippines, ethnic minorities in the Philippines. Most likely the health risks is not because they're engaged in poorer lifestyles. I would argue that they may be placed in environments that were in their more they're more agentic with their natural resources, pero like access to health, access to annual physical exam, wala sila nun, Next, we have, some men, again. So, men are socialized for risk, higher rates of smoking, binge drinking, and violence, which of course leads to injury, disability, and death, and more likely to meet aerobic exercise guidelines because, again, being sweaty, such a male-coded aesthetic and mannerism. But of course, there are paradoxes, like, for example, Black versus Latina populations, lower rates of exercises and drinking less than whites, yet suffer worse health outcomes. So, ibig sabihin, this may not be a function of health behavior, but a function of, when you get to the secondary prevention or the curative component, do they have access to the curative component of care? So that's another question. Like I said, if you are a healthy person in rural populations in the Philippines, I would argue like you're healthier because you're less exposed to toxic pollutants, right? Pero when someone from the urban area and the rural area gets sick, mas mataas yung access ng nasa urban area to healthcare that is specialized as opposed to someone from the rural area. So yun. And then of course, the built environment, the zip code, predicts genetic code. Like we have, and even in the Philippines, this is true. There are food deserts and obesogenic cultures. So in this, may access ka ba sa gulay? May access ka ba sa pagkain na mataas? So like for example, although this is a very, very matagal ng example, way earlier decades, there was an argument that those who live in the upper lands in the Philippines are more likely to have goiter. So goiter, we don't hear about goiter so much na anymore. So when public health is done good, okay naman, But goiter is when your thyroid gland, which is positioned in your neck, becomes enlarged because of lack of iodine. Iodine helps the thyroid in creating thyroxine. So when you have lack of iodine in the blood, it overworks the thyroid gland, thus making it increase its size, hence goiter. Many decades ago, they were arguing na if you're living in the uplands, saka nakukuha yung iodine, food from the sea. So dahil mas malayo sila from the sea, they have lesser access to that, So, but this is many decades ago. So what were the public and nutritional health actions for that? So dito na nauso yung tinatawag nating iodized salt, So you don't have to necessarily eat, seafoods, which of course you can just imagine kung gaano ka mahal ang hipon in Baguio, for example, So even if you have not much access, no, to see foods, you still get the normal recommended daily allowance for iodine through iodized salt. And then, ano pa yan? Iodized salt, parang dati, fine pa yan. Fine salt. And ayaw pa ng mga tao nun kasi nga parang mas madaling gamiting panluto yung rock salt than iodized salt. So eventually our nutritionist food scientists, came up with making the iodized salt also rock salt. And that's an example of a good public health activity, right? When there's a problem with food fortification is very important, right? If there are food deserts, particularly, we fortification. Yeah. This is important when you have micronutrient deficiencies and there are areas wherein the source of the micronutrients aren't abundant, and for people who may not have the money to, because of supply chain, so mas mahal siguro yung pagkain na yun. So if you fortify like food, like, so example, so kunyari kulang sa protein, merong mga gumagawa sila ng mga protein powders from anchovies, dilis. Protein powders from munggos to increase the protein content of what they're eating, hindi mas masyadong mahal. So food fortification is one of the better community health. No, I don't know kung nasaan na tayo in terms of that, but this is one of what I would say is a very empowering public health way, to address nutrition issues. Anyway, so again, the safety gaps also, right? Walkable cities, runnable cities. Iba, syempre, pag nakatir ka sa BGC, you're more incentivized to run. Diba? As opposed to when you're living in a dense populated neighborhood na madaming pollutants. Diba? Those kinds of things, right? So, ayan. And then, of course, we can think of other upstream factors like trust, political polarization, distrust, and then misinformation ecosystem architectures. No, I don't have to explain this in greater length because, you lived through this in the time of the pandemic where there's a lot of misinformation. There are a lot of discursive strategies that are being used, humor, conspiracy theories, about COVID-19, about the vaccine, and how it is related to political allegiances, So yeah, it's really not just, structural issues, but also political issues, And then, of course, we have the case study, we have vaccine hesitancy, and anti-vaxxer movements. Ayan. Diba? These are because of misinformation. Many people benefit from misinformation. We can talk about this more, in the medicalization of society, pharmaceuticalization of society, Who benefits? No, we always think about misinformation and we always think about who benefits from misinformation. Which industries, which corporate interests are centered, in conversations around misinformation. When you look at how the history of how smoking used to be advertised by doctors before, imagine, And that's the reason why policy is important. Policy is super duper important in changing behavior because you are, fighting against corporate interest here. Well, ideally, So policy sort of decreases the structural barriers. It incentivizes health behaviors. It provides funding for health behavior. So policy, rather than just me teaching you what to do, policy, structural changes will always be important. And we've seen that in mental health. Why are we having a lot of conversations about mental health now? Because your hospitals, your schools, your workplaces are mandated to talk about them with you. That is a mandate of the RA related to mental health. Why do you know a little bit about HIV, even if I didn't talk about it here? Because it is mandated by the HIV law that workplaces and education institutions have to talk to you about HIV at least annually. Why did we if there weren't policies, then the COVID-19, of course, we have questions about how the policies were thought about and implemented in the Philippines during COVID-19. But without these policies, we'd have more COVID-19 infections than ever. So, policy is very important in terms of adjusting behavior. It's either we want to stop behavior, or we want to encourage behavior, or we want to modify those behaviors. Also very important is the idea of contagion and homophily, about how strong your social networks is. Kung ano yung health behaviors ng mga taong nakapaligid sa'yo, you're more likely to act like them. So for example, obesity and smoking spread through networks like virus, like people who are close to you. When you have more friends, more family members who are obesity, it also at risk for you to, be also obese or have obesogenic behaviors. Social clustering. Smokers were pushed to the periphery of networks over time. So, for example, when the opinions about smoking decreased, ibig sabihin, the government paints a bad image about smoking. The smokers now, medyo nahihiya sila to be with people, and so that deters them from the behavior. If a spouse or friend quits, the individual is significantly more likely to quit. So, ganon. I guess one of the important policies in the Philippines that sort of help improve health behaviors in multifaceted ways is the sin tax, Ibig sabihin tataasan yung tax, sa mga vices like smoking, vaping, alcohol, because we do know that smoking kills 240 people a day, and so there are many of our morbidity and mortality can be caused by smoking. But we see here now that the tobacco use has decreased after the sin tax law. What happens also is the extra tax that is being collected from the sin tax is actually funded, binalagay sa PhilHealth, nilalagay sa health services. So, it helps, right? And this is again also the same, in the States, adult smoking prevalence went down when you have end of agricultural subsidies, tax hikes, public smoking bans, kahit sa Pilipinas, public smoking bans decreases your engagement, and then lowering of sales. So nakita mo yung pagbaba niya. So again, policies can be used to deter bad behavior, bad health behavior. However, healthcare, many of the money goes to secondary and tertiary prevention than primary prevention. So primary prevention are the activities that we need to do to prevent diseases before they start. Secondary prevention is, when the disease is there, we want to cure it as immediately as possible before they become complications or become disability or deaths. In tertiary prevention, this is when you have chronic illness already and you have disability, you want to be rehabilitated so that you don't get more disabled. So that's tertiary prevention. Ideally, this is what we want to have more efforts and money put to primary prevention. But when you look at the Philippine system, it's actually an inverted pyramid. Lesser money put on primary prevention and effort and studies put in primary prevention, and then secondary prevention, and then tertiary prevention. Nandito lahat, sub-specs mo ng mga doktor, not very many primary health and public health doctors. What do we mean to say when we say primary health care, primary prevention? So common diseases management, kasama dyan yung vaccine preventable diseases, those that are we already have a lot of information about, no? Essential drugs availability, no? Kung may hypertension, makakakuha ba tayo ng mga anti-hypertensive drugs in the barangay health center? Vaccines in the barangay health center, are they available? And we have laws, no, in terms of controlling prices. Actually, when I look at the states, nakaka-stress yung ang taas ng presyo ng insulin, ang taas ng presyo ng mga antibiotics. In the Philippines, we have laws, that say na there are caps for these essential medicines. You cannot, charge higher, which is good. Which is good. Safe water access. Of course, water is very important. It is 70% of who we are. And so, having water is access to potable water is very important. Maternal and child health. Again, I explained about how maternal mortality rate and infant mortality rate are indicators of good health in a country. Immunization or vaccination. Disease control. No? Vector. How do you engage in vector removal? Vectors meaning mga mosquitoes na nagdadala ng sakit. Diba? So that's example of disease control. Nutritional promotion, health education. So, how much money do we put on this, over, let's say, defense spending, or over, let's say, spending for pork barrel, or some things like that, no? So, yeah, some things that we need to think about, no? Again, this also comes down to, political priorities, political will. And again, when you go to the LGU level, parang mas maganda kasing tignan yung nagbigay ka. Kasi 'di ba, the thing about political patronage is like mas magandang tignan kung mas malaki yung pera na nilabas ng politiko for your medical needs. Like it's more incentivizing for the politician to give free cataract surgeries or free LASIK surgeries to old people instead of promoting vitamin A, no? Because mas dramatic yung healing than prevention. So I'll talk about this more when we meet, no? But yeah, so those are some of the reflections that I have of how why there still is lesser attention put towards primary prevention. Although our laws, universal healthcare, that's very primary prevention, that's very primary healthcare. But there has to be some, a larger cultural shift within medical institutions, health institutions, to think more about primary prevention than doing curative or rehabilitative care. And then also, let's finally talk about, we always talk about sociocultural determinants of health, sociocultural determinants of health, but also we also have to look at commercial determinants of health. And I was talking earlier about policy and how it kind of balances corporate interests, but again, commercial determinants or corporate interests, the market forces are super duper strong in terms of, causing health illness. Like, for example, the political and economic system are so much intertwined, like you have political systems supporting industries that are selling a lot of trans fats, selling a lot of processed meals, building areas, removing walkable cities, building a lot of malls. So dahil may entanglements yung elite, as you would remember probably yung kay Wright Mills about the elites, those in power, the politicians, and the military forces, those are your elites, no? So they take care of each other, sometimes to the detriment of our health. Next is regulatory approaches and upstream policies, get affected by these choices, like for example, yung water issue natin sa isa sa politician who owns the water supply, diba? So because they're also in the spaces where regulation should have been done, where policy making should have been done, you don't expect good policy to come up to be against their interests, right? So yeah. And then sectoral and public policies that are increasingly influenced by reflect commercial sector interests. Like for example, tobacco companies, doing corporate social responsibility. So, like, ang hirap naman nun, di ba? So difficult to, like, talk about, if you are, so it's really weird for you, for example, as a medical institution, and then you take CSR money from tobacco institutions. Parang weird, di ba? But some do. So, again, when funding agency, looks into this particular interest, then sometimes the narrative gets changed. Like, for example, there's this conversation around, pivoting from sugary foods to exercise. There's a lot of funding put by Coca-Cola on exercise research, and a lot of media attention put on that, so that we realize that it's not really about what we eat, but it's actually the extent to which we exercise to get the heat off sugary beverages. But now we're changing our paradigm, and these are some of the things, why in research we have to say that this particular research is funded by this, so we know corporate interests ba to, etc. And then of course environment. Bakit ang daming mall? Bakit ang daming factories? Right? Bakit wala tayong access to potable water? This built environment is shaped by the imaginaries of corporate institutions, sadly. And then they work together with political elites. And so what happens is that ill health and health inequities. Yeah. And so in terms of promoting health, this is what we sort of look at, So this is a multi-dimensional way of health promotion. So you focus on the socio-ecological recipients of care. So you talk about individuals as recipients of health promotion, families and peers, communities and schools and workplaces, the whole sectors and society. And then what we also attend to the different socio-cultural determinants of health, like income and social status, social support and networks, education, working conditions, physical environments, the actual biology and genetics of the person, personal health practices and coping, healthy developmental milestones, health services. And then we have strengthen community health and action. So we have ito yung mga activities ngayon for health promotion. So it's either we strengthen community action, so we organize people so that they'll be able to do health promotion. We build health public policies. Example would be the syntax law, would be the HIV law, the responsible parenthood act, act. We also have the mental health law or the mental health act. Yeah, so these are examples of good health policy, public policies. Again, of course, the implementation is another issue, but yeah, we have those. Creative supportive environments. Again, the built environment and the social environment, very important in improving life chances, to get health behavior. Develop personal skills, capabilities to actually do the behaviors, and then reorient health services, from this to this, wherein primary healthcare is seen as a priority, And so dapat evidence-based, syempre, and the decision making of people is based on their assumptions and their experiences. And so research are very important for us to be able to get more evidence. So this is the health promotion model, a multifaceted health promotion model being forwarded by WHO. So that's sociology of health behavior. So again, if we're going to sort of have a synthesis of the conversation that we've had, we always think about behaviors as an individual thing, an individual choice. And so what happens is that when a person gets sick, then that individual is to be blamed. But we learned from this particular session that fundamental causes actually inhibits or facilitates our life chances, and the expansion of the choices that we have to empower ourselves in terms of the health behaviors that we're able to do. So in the next session, we'll talk about illness behaviors naman.